collaboration and this annual meeting from its inception in 1994. And this is the 22nd David Murdock Lecture and 26th year of Mayo Karolinska meeting. This year, we are extremely fortunate to have two outstanding speakers to talk about a problem that is very much relevant to all of our lives. And it's my privilege and honor to introduce Dr. Anthony Fawci. It is almost superfluous trying to introduce Dr. Fauci to any scientific audience anywhere in the world. Dr. Fauci is the director of the National Institute of Allergy and Infectious Diseases since 1984. Besides his leadership role, he is also a celebrated scientist who has made many seminal contributions in basic science as well as clinical research related to pathogenesis of immune-mediated and infectious diseases. He is top ranked among the 41 most highly cited researchers of all time. He is a recipient of numerous prestigious awards, including Presidential Medal for Freedom, National Medal of Science, and Lasker Award. In 1998, I had the opportunity to listen to his talk at the Association of American Physicians, where he received the George M. Kober Medal, which is probably the highest award any physician scientist in the United States can receive. And interestingly, in that meeting, unlike all other awardees, the leaders of the AAP requested Dr. Fauci to share his experience in dealing with 5 different presidents belonging to different political parties. I were all impressed by his integrity and the adherence to the facts and truth in dealing with different political leadership. He is now serving the sixth American president as an advisor to COVID-19 pandemic. Once Dr. Francis Collins described Dr. Fauci as a national treasure. So it's my huge pleasure to invite our national treasure, Dr. Fauci, to give the 22nd David Murdock Lecture. Dr. Fauci.
Dr. Nair, it's really a great pleasure to be with you today and to deliver the David Murdock Lecture. I would like to see if I could get my slides up, and which I think they're on their way. Okay, very good. So shall I start? We're good?
Yes, please.
Okay, as you can see from this first slide, the title of my talk is The Public Health and Scientific Challenges Associated with this extraordinarily important and historic pandemic, which we are all experiencing throughout the world at the present time. I want to start off by showing the cover of this journal of a perspective viewpoint that I wrote in January of 2020 at the very beginning of the evolution of this pandemic. And the title that I chose for the viewpoint was Coronavirus Infections More Than Just the Common Cold. And I used that title not to be facetious at all, but to point out to people who may not have fully appreciated that we have decades and decades and decades of experience with coronavirus, and only in the last couple of decades has in fact the situation changed somewhat with the evolution of the pandemic potential of these viruses. So let me talk to you a little bit about that. This is the phylogenetic tree of coronaviruses, and there are a number of human coronaviruses that are indicated in red letters. Of note, 4 of them that have the yellow shading are the coronaviruses that are responsible for about 15 to 30% of the recurrent common colds that so many of us get each year, usually during the winter months. If you look at this slide, the 2 that are now highlighted in yellow are the SARS and MERS, the severe acute respiratory syndrome, which appeared in 2002, very likely jumping species from its natural reservoir in a bat to an intermediate host, which at the time was felt to be a civet cat, to a human. That led to an outbreak of 8,000 people with close to 800 deaths. That was 2002. And then MERS in 2012, again, went from a bat to a camel to a human. So we'll go through that and show you how that actually evolved. So these are the two pandemic coronaviruses that I just introduced you to. The severe acute respiratory syndrome emerged in the Guangdong province of China in 2002, and somewhat similar to what happened here, it was felt to be an atypical type of pneumonia until individuals went from Guangdong to Hong Kong, stayed at a Metropole hotel in Hong Kong, and then from there flew innocently and unaware to various parts of the world, spreading what would become the first, at least in our own memory, the first coronavirus pandemic. And this is the map of the world showing the 8,000 cases and almost 800 deaths. Again, fast forwarding to 2012, another emergence of a pandemic coronavirus. As I mentioned, this time from a bat, likely to a camel, to a human, emerging in Saudi Arabia and staying in the confines of the Middle East with few exceptions of travel-related cases, and still today, some smoldering cases. These are the number of cases of MERS from 2012 to the present time, similar to SARS. It had a very high case fatality rate, but relatively little capability of efficiently transmitting from human to human. So now fast forward to the present time, and we are experiencing yet again another pandemic coronavirus, which appeared in China in the Wuhan district of central China at the end of December of 2019 and the first week in January of 2020, when the Chinese identified this as the cause of a pneumonia-like outbreak in a wet market in Wuhan. It was felt to be, in the beginning, just a jumping of species from an animal to a human, until it became patently obvious that this was a very efficiently transmitted virus, that it had adapted itself very well to the human species. And that's what we are now calling SARS coronavirus 2 because of its phylogenetic proximity to the original SARS coronavirus 1. So to be clear with the terminology, the disease is referred to as COVID-19 for coronavirus disease 2019. And as I mentioned a moment ago, the virus is referred now to SARS coronavirus 2. And here we are now, having literally exploded upon the world, the most historic pandemic that we've experienced in the last 102 years since the 1918 pandemic, referred to as the Spanish flu. So currently throughout the world, there are close to 30 million cases and close to 1 million deaths. Each day, these numbers grow and grow, and I'm sure as the weeks go by, you're going to see this get bigger and bigger. Unfortunately for us here in the United States, we as a nation have been hit harder than any other country in the world, with the latest count as of yesterday being 6.3 million reported cases and about 190,000 reported deaths. The distribution of cases are shown in this heat map throughout the United States, and note the recent concentration of cases in the southern states. If you look at the reported cases per day, the curve here for the United States is disturbing in many respects, and I will explain. If you look here at this slide, the peak that was seen with the European Union went to a certain point, and then came back down to a low baseline below 10,000 cases per day. Only recently, with attempts to open up the economy, has the European Union began to creep up in daily cases. But take a look at the United States, that peaked a little bit later than the European Union, but it never went down to a reasonable baseline, hovering around 20,000 cases per day for literally months until June and July, when we began to try and open the economy, particularly in some of the southern states like Florida, Texas, California, Arizona. There was a rather substantial surge, so that the daily cases went up for several days to 70,000 cases per day and at least 1,000 or more deaths. Up to today, we now have a baseline of anywhere from 36 to 44,000 cases per day, which is an entirely unacceptably high baseline of infections. Why did this happen? Why did our baseline never get down to as low a level as we would have liked? The reason is we as a nation did not, quote, shut down, unquote, to the extent that our European colleagues did. If you use Italy and Spain as representative of the European Union, you will see that when you do measurements that reflect the degree of shutdown, such as people visiting parks and outdoor spaces, look at the difference between the dark line representing the United States and the lighter lines representing Spain and Italy. That's for parks and outdoor spaces. If you look at workplace attendance, again, the United States did not nearly go down as low as representative European countries. And finally, visits to grocery and pharmacy stores, the United States again did not go down nearly as steeply as Spain and Italy. So we feel that's at least one of the reasons why, although we did have varying levels of shutting down, we never did it to the extent of our European colleagues. So let me move on now to the virology of SARS coronavirus 2. It is a beta coronavirus, an RNA virus. It has 4 structural proteins, particularly the S or spike protein, and the receptor is the ACE2 receptor, which is widely distributed on a number of tissues, including upper and lower respiratory tract, GI tract, and now, as we're starting to realize, other tissues such as cardiac and neural. The spike of the coronavirus itself is now being intensively studied, and shown in the green line on the upper right is the receptor binding domain, which binds to the ACE2 receptor, which actually was discovered as the receptor for coronavirus back in the days of SARS coronavirus 1. Transmission. We all very well know now that this is a respiratory transmitted virus and is transmitted between people usually in close contacts, as is the case with most respiratory viruses. The transmission is via respiratory droplets and particles of various sizes, including increasing evidence of late that aerosol particles is playing an increasingly important role in the transmission. Surfaces can be infected, and virus is found in a variety of body fluids, but the degree of which this plays a role in transmission is unknown at present. Animals, including zoo and domesticated animals, can be infected, but again, we do not feel that this is playing a significant role in transmission. This shot here shows the extent with which particles can be emitted in a typical sneeze from an individual shown here on the left-hand side of the slide. But as I mentioned, even breathing and especially singing and talking can emit replication competent and transmissible virus. And we know that now as a fact and a matter of evidence. The risk of transmission varies depending upon the type and duration of the exposure, as well as the kind of preventive measures that have been put into place. Secondary infections are most common among household contacts, which is the reason why we say even among people within the family, if you don't know your status, you should be wearing a mask. Numerous clusters of cases occur after social or work gatherings, and that highlights the risk of transmission through close contact. Here are some examples of the kind of spread that occurs in enclosed places. The now famous spread of the choir in Skagit County, Washington, where one member of the choir was symptomatic and spread it to 87% of the people in that room where they were singing together. In addition, there are other examples of family gatherings, such as weddings and other celebrations, as shown by the Chicago incident in February of this year, as well as attendees at church events, as shown by the Arkansas outbreak in March of this year. One of the most perplexing aspects of this particular virus is the fact that now we know about 40 to 45% of all the infections are without symptoms. And importantly, we now know that modeling studies are estimating that approximately 50% of all the transmissions occur from an individual who is without symptoms to an uninfected person. There are personal preventive measures that have been proven to be successful, such as diligent hand washing, avoiding close contact, the 6-foot rule, importantly, covering the nose and the mouth with a mask or a cloth covering, and regular cleaning and disinfecting of touched objects, as well as the obvious things of avoiding face touching and covering sneezes. There are broader public health measures, such as the orders for distancing, stay-at-home orders, business and school modification of schedules, as well as closures, bans on public gatherings, entry or exit travel restrictions, as well as the typical identification, isolation, contact tracing, and quarantine. Moving on to clinical manifestations. Now we know very clearly that the median incubation time is about 5 days with a range of 2 to 14 days. The symptomatology is strikingly similar to a flu-like syndrome, as shown on this slide with the various manifestations. A curiosity is, in many patients, the loss of smell or taste, which precedes the onset of respiratory symptoms. As I mentioned, 40 to 50%, 40 to 45% of individuals are without symptoms. Those with symptoms overwhelmingly have mild to moderate symptoms, not requiring any specific intervention, about 80% of individuals. Of the 15 to 20% that have symptoms that are not mild, they are severe and in some cases critical, with a case fatality rate ranging from around 3% to up to 20 to 25% in people who require intubation and mechanical ventilation. The manifestations of severe COVID-19, the most common being the acute respiratory distress syndrome, but also there's hyperinflammatory syndromes, including involvement of the heart with arrhythmias and cardiomyopathies, sometimes leading to sudden death, kidney injury, neurological injuries, thromboembolic phenomena such as microthrombi in small vessels, and stroke with larger vessels, sometimes in younger individuals. And then there's the multi-system inflammatory syndrome that are seen now in increasingly numbers of children, which is strikingly similar to Kawasaki disease. The people who are at increased risk for this severe illness are divided into two groups. The first being older adults. And this slide very dramatically shows the differences in rates of hospitalization per 100,000 population, with a very low number on the left-hand side of the slide of younger individuals, but a striking increase as you get to those in their 70s and 80s, which have a very high level of a rate of hospitalization. In addition, there are people of any age who have certain underlying medical conditions. Those that have a strong association with a risk of severe disease are shown on this slide, particularly those with heart conditions, chronic kidney disease, chronic obstructive pulmonary disease, diabetes. Obesity seems to be one of the most predominant of these, as is other diseases associated with immunosuppression. The other conditions that may confer an increased risk are shown on this slide. I want to point out at least one of them that is really important, that appears to be an association, is hypertension, in addition to type 1 diabetes and other lung and cardiovascular disease. One of the important things to point out is that in the United States, there's a considerable proportion of the population have the underlying conditions that make them susceptible to severe disease. For example, if you look at any underlying condition, about 40% of individuals fall in that category, and about 30% of the people are actually obese, a strikingly high percent. But again, as I mentioned a moment ago, these individuals have a significant risk of a severe complication. Unfortunately, we have in this country a great disparity along racial and ethnic lines, with a much greater burden of infection and disease among African Americans, Latinx, as well as American Indian, Alaskan, and Pacific Island natives. Here again, if you look at the rate of hospitalization, look at the sharp difference between Blacks in the upper bar with 333 per 100,000 hospitalization compared to whites in the lower bar with 71. This, as you might expect, spills over into deaths, where you look at the deaths per 100,000, and again, African Americans are at 90, whereas whites are at 38. Quickly, diagnostics, 3 major types. One for the virus itself, which is usually a molecular test using polymerase chain reaction, a swab in the nose or the back nasopharynx. This is one for specific diagnosis. We have antigen tests that detect proteins from the virus, can be used at a much larger scale and high throughput. And then there are antibody tests that determine if a person actually has been infected. The diagnostic tests that we use fundamentally should be amplification of RNA, whereas, as I mentioned, screening tests generally use the antigen test. And most recently, I bring to your attention that Abbott has a Binex Now kit, which is really the size of a credit card, requires no specialized equipment. You get a result in 15 minutes, and it has a very high level of sensitivity and specificity. These are starting to be widely used now, have been a major purchase on the part of the federal government to be used in nursing homes, schools, and other places where you need to do rapid screening. Therapeutics. There are a couple of drugs, which I'll get to in a moment, that have been shown in randomized placebo-controlled trials to be effective and are recommended by the NIH guidelines, again, which I'll get to in a moment. But there are other drugs that are under investigation in a variety of clinical trials, even now as I speak to you. One are specific antivirals. Other is convalescent plasma and hyperimmune globulin, still testing whether or not these really are safe and effective. A number of studies looking at monoclonal antibodies. There are immunomodulators like cytokine inhibitors, as well as anticoagulants for the hypercoagulable state that I mentioned. I want to just specifically mention Remdesseviere, which was the first drug shown in a randomized placebo-controlled trial with a large number of individuals, about 1,000, shown to have a significantly positive effect on decreasing the time to recovery in people who are hospitalized with lung involvement. A study from the UK, also a randomized placebo-controlled trial in thousands of individuals with advanced disease requiring ventilation as well as oxygen, showing that it decreases substantially the 28-day mortality. And again, as I mentioned, these two studies are now recommended in the NIH guidelines. The glucocorticoid effect has been underscored and confirmed by a meta-analysis of a number of other studies. So very clearly, when you have a person with advanced disease, particularly those on ventilators or requiring supplemental oxygen, that the inflammatory response that's muted by the steroids clearly has a beneficial effect. As I mentioned, the United States, under the NIH auspices, has put together a treatment guidelines panel, which in essence is an online living document that is updated on a regular basis to provide for clinicians clinical data from clinical trials, as well as some unpublished expert type data. And again, this is a living document that is frequently updated, and we recommend it for people who want to keep up on what the latest clinical recommendations are. And finally, vaccines. We have taken a strategic approach to the 6 or 7 candidates that are being tested in the United States. And by a strategic approach, I mean a harmonization of the protocols with a common data and safety monitoring board, common primary and secondary endpoints, and common immunological parameters that are being followed. This is a list of the various platforms that are currently under clinical trial, with the companies listed in the middle of the slide. There are nucleic acid platforms, predominantly messenger RNA. There are viral vectors, including adenovirus, human adenovirus, chimp adenovirus, VSV, and measles. And then there's the typical classical protein subunit with or without an adjuvant. Note in the upper right-hand part of the slide that 3 of these are in phase 3 trial, 2 of which have started at the end of July and are 2/3 enrolled. And as I mention often, we expect that by the end of the year, November or December, possibly early into 2021, that we will have vaccines that are available that have been proven to be safe and effective. You can never guarantee anything when you're dealing with vaccine development, but we feel cautiously optimistic that we will in fact have vaccines that have been proven to be safe and effective and that will be available as we enter into 2021 and throughout the year. This is an online indication of our COVID-19 prevention network, which gives you information about the trials and allows you, if you have any interest, of actually signing up with the intent of volunteering for one of the vaccine trials, which we would welcome, merely by logging on to coronaviruspreventionnetwork.org, as shown on this slide. And finally, on the last slide, just a couple of weeks ago, my colleague David Morins and I wrote a perspective in Cell entitled Emerging Pandemic Diseases, How We Got to COVID-19. And it really is a discussion of the kinds of factors, particularly the perturbation on our environment and the human-animal interface, which is becoming increasingly more important, which has led to the COVID-19 outbreak, and which will hopefully, if we consider this, give us lessons learned about how we might prevent or at least be prepared for the inevitability of subsequent outbreaks. So I'll stop there, and I thank you for giving me the opportunity to make this presentation.
Thank you, Dr. Fawci. I want to introduce Jan Andersen, our colleague from Karolinska Institute, who himself is an infectious disease specialist.
Thank you so very much. And dear Dr. Fauci, thank you so much for a fantastic talk. Thank you for sharing your wisdom and your scientific knowledge with us. You have served the American public health in various capacities for more than 50 years. And no wonder that I now have the honor to bring forward to you a few questions that has been transmitted to us and that I would like to share with you, Dr. Fauci. I would like to start with what's on everybody's mind. If we look at the global level, like you just pointed out, how should we ensure a fair and equitable distribution of effective, safe COVID-19 vaccines based on needs and resources once they become available on a global, international level?
Yes, that's a very good question and an extraordinarily relevant question. The thing that I'm encouraged about with regard to this is the number of companies that have now gotten involved in developing a vaccine and the promise and already pre-purchasing of literally hundreds of millions, if not billions, of doses of vaccines. Not only ones that are being produced in the United States, because we now have pre-purchased vaccines that are well in excess of what we need in the United States.
Right.
We know the UK is doing the same thing. We know that Russia and China and India will be doing the same thing. The WHO has formed a consortium to try and make sure that, in fact, we will have the equitable distribution so that no country or region suffers because of the lack of resources of being able to get a vaccine. So I'm optimistic, Dr. Anderson, that when we get a safe vaccine, as a global community, we will assume the responsibility of making sure that this is equitably distributed.
That's really reassuring to hear. For us, it has been obvious that during the COVID-19 epidemic, it's obvious that in-depth assessments of outbreak preparedness needs to be beyond public plans. Why is it so hard for us to predict the level of preparedness, like you just pointed out for us in the behavior in the United States?
Yes, a very perplexing issue. You know, one of the ironies of all of this, Dr. Anderson, is that we in the United States, in anticipation of a pandemic influenza, developed a pandemic preparedness plan several years ago. And we were judged by a panel that was put together by the Johns Hopkins School of Public Health to be the best prepared for a pandemic of any nation in the world. And looking at the slides that I showed you, we did worse than any nation in the world. So that is something that we really need to take a very close look at not only the resource issues, but the understanding and the cooperation of the population in understanding what you need to do. I mean, there are so many things that hopefully we've learned our lesson with. You may have been following it in the news, but when I would get up at the White House and say, we absolutely need to go by these guidelines of opening, phase 1, phase 2, phase 3. And what happened is that we saw the numbers on the slides I showed you. When we tried to open up, particularly in the southern states, either they didn't pay attention to the guidelines or they professed the guidelines, but the population decided they didn't want to do it. So we really have a lot to learn and a lot more things we need to do to be prepared for the next outbreak.
What do you think? Can we do something to promote the acceptance of scientific facts by the public and political leaders then? Are there other means now? You and I are communicating virtually in this way. We haven't met since 13 years ago, and yet we can do it. But why can't we communicate to the others, to the political, to the public domain, with the knowledge that you share right now?
Well, we have to keep trying, and we have to be transparent in everything we do. We've got to make sure that we're humble when we do not know the answers to things, to say we don't, because when we start guessing and giving information that turns out not to be true, we lose credibility. I think an important part of the communication is the maintenance of credibility and consistency in a message. I don't think that's the total answer, Dr. Anderson, but I think that's really important that we do that.
But a really difficult question for you is, of course, when I ask you, if you were to look in the mirror now, and it was instead the week 10 or something like that, and you were to redo the job you have done so intensely and so heavily, would you think of other ways to do it than what you have actually done these, I would say, 7 months soon?
Yes, we go through that exercise a lot back home. I know everybody.
Me too.
You do it in Sweden. You do it everywhere in the world.
Right.
Is that you always can go back and say you should have done things really differently. Perhaps recognizing as a nation earlier the potential of this virus to spread so efficiently that closing down more quickly and more thoroughly. We try to walk that balance that came back to bite us. We wanted to shut down, but we didn't want to shut down so much that it would really completely destroy the economy. And it turned out that at the end of the day, by doing that, we may not have done it as well as we should have done it.
Right.
So that's probably one of the things we would have done differently.
So a change in topic, in contrast to influenza, which has its very rapid replication and drop, it seems like COVID-19 infection is much more prolonged in its virus replication pattern, in some patients weeks even. So why haven't we been able to develop better antivirals as of yet? You who are so involved in the HIV antivirus and the development, why hasn't we done a better job in that area?
Yeah. Boy, that question is a good question, but a painful question, because right now when I think about it, maybe because it was so acute, Dr. Anderson, that we felt we needed to go and get things off the shelf.
Right.
Remdesseviere, dexamethasone, as opposed to what we did so successfully with HIV, where we examined and completely delineated the replication cycle, targeted protease, targeted integrase, targeted all the enzymes.
Yes.
I'm absolutely positive that if we put that kind of effort into targeted antiviral design, there's no reason why we couldn't get the same types of antivirals
Yeah.
the COVID
Yeah.
that we got for HIV.
Yeah, a very interesting remark. So do you actually seem to believe there is evidence for individuals then responsible for super spreading the SARS-CoV, like you pointed out? Is this a tremendous variation in viral load from individuals, or is it the behavior? Or
no, I actually think, I'm glad you asked that question. I don't think there are as many super spreaders as I think there are super spreading events. So you could have someone who is secreting a modest amount of virus, but when you're sitting in a closed choir room and everyone is singing, then you have a super spreader event.
yeah,
You don't necessarily have to have someone who inherently is spewing out so much virus. You're in an environment where it's so easy to spread.
right. So that's a completely different ballgame and picture you're pointing out.
Yeah.
Very, very important, Dr. Fauci.
Yeah.
So what are the lessons now that you have learned from your experience with HIV that you actually have been able to apply here in thinking about how you have been thinking how to handle the COVID-19 pandemic? Are there similarities or are there more dissociated events in that part? How to deal on a nation?
Yeah. You know, I think there are more differences than there are similarities,
Right.
because of the chronic nature of HIV, the restricted ways of transmitting it, the ease of preventing by mere behavioral changes, the long latent period of a person feeling well for years and years before they deteriorate. There really are so many differences. I just think an acute, highly transmissible respiratory infection is so inherently different than what we've dealt with HIV.
Right. There is inflammation in both settings, but this cytokine storm that is associated in quite a number of patients with the COVID-19 infection, how is that occurring? What is it inducing this? Is it an enormous virus replication, enormous cell death, or is it just a triggering of the innate immune response?
You know, I think more the latter. You know what I think? I first of all, I have to be totally honest. I do not know the answer to your question, but I think it's beyond a specific immune response to a pathogen. I think there's something about the spike protein or other epitopes on the virus that are aberrantly triggering an innate immune response that's letting out an entire cascade of inflammation. I don't think it's specific immunologic, more non-specific triggering of aberrant response.
Yeah. And hence the effect of steroids then.
Yes.
Yes. Dr. Fauci, I have to end here. I would have loved to speak more to you for years or hours and yes, with all your tremendous knowledge, going from the epidemiology to the virus, to the inflammation, to the handling of this complete, very, very complicated new pandemic that we're standing for. I on behalf of the Murdock Lecture, I would so much like to thank you for your enormous contribution, sharing all this knowledge with us, letting us spread this to the world. So thank you once again for your participation in this. Thank you so very much.
Well, thank you, Dr. Anderson.
We usually give a plaque and some money. You said that you cannot accept any money from us, but we'll send this plaque to your office. If you have any space left on your wall, you can hang it there. We'll be honored.
Yes, thank you, Dr. Nan, and thank you both for giving me this great honor. And it's really good to see you, Jan, after so many years.
To Tom,
We're
you're
both
welcome to Stockholm. We have the same color in the hair nowadays. You're so welcome back here.
Thank you.
Thank you so very much. Bye-bye.
Bye-bye.
Bye.
You want to go ahead? I think you are muted.
Should I continue introducing?
Yes, please.
Thank you very much, Dr. Nair. So it's a big honor for me to introduce the next speaker, Dr. Anders Stegnell, at the State Epidemiologist at the Swedish Public Health Agency. His ideas has imposed quarantine measures in Sweden that has attracted a lot of international attention. The Swedish strategy has been somewhat different, and it has been described as a trust-based instead of a wide-ranging bans and restrictions. Authorities have advised people to maintain good hygiene and work from home if possible, and practicing very distinct social distances. What most people are not aware of is that he has a long experience in measures for global health. He's had a key role in 2009 swine flu epidemic. He has previously also worked for the European Commission to prepare for public health infectious disease threats. And in the WHO, he formed a Swedish expert team during the 1995 Ebola outbreak in Congo-Zaire. Thus, it's a pleasure to me to invite Dr. Tegnell to speak.
Thank you very much for the kind invitation and for this honor to speak at this very nice event that you have set up. I'm also very happy to have listened to Dr. Fauci's description of the scientific background to this virus and to the epidemic. And I think then my presentation, which will be more focused on the handling of the epidemic in a smaller country like Sweden, will fit quite nicely into that context. I will try to get my presentation to get it started. So I will talk a bit about how we worked with the pandemic response in Sweden. And I think it's, as I said, I think it's good for you to have the background from Dr. Fauci's presentation of the virus, the disease and so on, because I will not talk so very much about that, but more about how we've been handling it in Sweden. I think also the experience in Sweden have differed quite a lot from the experience in the United States. And I think that once again shows us how very difficult it has been to understand this virus, the epidemiology and the pathogenesis of this virus. It keeps on surprising us in many ways. And I think it's important to remember that it will probably keep on surprising us also in the future. But just to give you a quick background on Sweden, to put you in the context, because I think the context is unusually relevant when you talk about COVID-19 and how to handle it, because quite obviously you need to handle it very differently in different settings. And some of this will come back to the difference between the United States and Sweden in many ways, which will also probably to a certain extent explain why we need to handle it different in different countries. So we are a small country in the very north of Europe, 10 million inhabitants, with an elderly population. We have at least 20% of the population is above 65 years of age, which is important to remember when you think about the mortality associated with old age in this disease. We have, I think, compared to the US and compared to many other countries, a very high level of public health. Our life expectancy is very high. Males more than 81 years and females more than 84 years. We have a very low maternal and child mortality. And we have had that for quite some time. It's also important to remember that we have a very decentralized healthcare system. Even being a small country, we have very independent regions that runs our healthcare. But our healthcare is universal. It reaches everybody. It's publicly financed and it's heavily subsidized. And the need for individuals to pay in when they get sick is very, very small. So the governing structure is also important to remember when you think about how different countries handle this in different ways. As you can see in the government, there is of course the Minister of Health and Social Welfare, but then there is a number of different agencies in Sweden. The Swedish agencies have a long history, 300-400 years back, as being very independent and also taking a a very big part of the management of different crises and the division of labor between the political level and the agency level is quite different in Sweden than in many other countries, where the agencies taking a much bigger part in the handling of any kind of an event, and also of daily running of health services and public health. Our structure also, when it comes to handling this disease, is very much dependent on the policy and legal framework. We have a Communicable Disease Act that very clearly gives a lot of responsibility to the individual to keep from spreading a disease. So it's very much the individual's own actions that are important and how he handles those. There is a public health policy framework talking very much about the equity of health in Sweden. As I said, there is a very high level of autonomy for in the different Swedish regions, and that has led to the shared responsibility between the regional, national, international level in this area. And these 300-400 years of having very independent agencies in Sweden have, over time, developed a very high sustained level of trust between the agencies and the political level and the citizens, which I think is also important to remember. As I said, Sweden is divided into 21 regions and more than 290 municipalities. And all of these are very independent. They have their own political leaders. We are taxed at 3 different levels in Sweden. So it means that altogether these different levels of administration are very independent. And most of the operational issues when it comes to any kind of crisis, and also this pandemic, is actually run by the county, by the counties, by the regions, and the county medical officers. There's one county medical officer in each region who has a fairly small staff, because most of the interventions are actually done by the health services. The municipalities are also important. They're running schools, they run long-term care facilities, which we're going to come back to, because they're quite important when it comes to the COVID-19 and the response we have to COVID-19. So the Public Health Agency in Sweden, just very briefly to also give you some background, because I think that also makes a kind of difference to why we handle it the way we did. The agency has a very broad responsibility in the area of public health. We work with non-communicable diseases, we work with drug abuse, health inequalities are very important for us to work with. So there's a lot of different things we do. But we are also the coordinating body for the communicable disease prevention and control in the country on a daily basis. We are a kind of national reference laboratory, and we do collect, analyze, and report a lot of data all over the public health field. We have a very strong, I would say, reporting system in Sweden, which is web-based with a web tool that reaches all physicians in Sweden, reaches all clinical diagnostic laboratories in Sweden. And there's a legal obligation for each physician and each laboratory to report around 80 communicable diseases as soon as they find them through this system. And getting reports both from the physicians and from the laboratories gives us a very high level of reliability when it comes to the cases, and we have a very high level of the amount of cases that we actually find. At the Public Health Agency, our laboratory is mainly doing public health laboratory work. We do typing and also quality control for the laboratories out in the countries. So what happened with COVID-19 in Sweden so far? I'm not going to spend so much time on this, but just for your reference, it's good to know that we have had 86,000 confirmed cases so far. As you know, this is most likely only a small fraction of all the cases in all countries. We most likely only find a fraction, maybe 10-15% of all cases that we have. All the others we'll never really find. We have so far treated around 2,500 patients in intensive care units all over the country. We have a fairly high level of deaths, 5,800 so far, and I'll come back a bit to explain more about that. About 50% of those took place in nursing homes for the very old, very multi-sick people. We had a fairly rapid peak early on, but during the summer and also now until now, basically, we had a very sharp decline of cases. We peaked somewhere in the late March, early April, and then had a slow decline. But during the summer, the decline has been rapid, and we're now down to less than 200 cases a day, which means that we have fewer cases per capita than almost any other country in Europe right now. We have the one thing that many people look at is the high level of mortality in Sweden, especially when you compare it to our neighboring countries. If you compare it to the UK, the Netherlands, France, almost all other countries in Europe, it does not stand out in the same way. But when you look at other Scandinavian countries, it is different. And there is, of course, a number of different factors, but the main factor is really that very high proportion of the people that died lived in nursing homes, and we had a huge number of introductions into nursing homes. The nursing homes proved not very well prepared, or at least not all of them very well prepared for this pandemic. And that meant that there was quite a lot of introductions into the nursing homes. And as Dr. Fauci also shows, once you get disease into that group of people, the mortality will be very high. Why is it then higher than in the other Nordic countries? It's something that needs to be more evaluated over time. We had a much bigger introduction into Sweden than we had in most other countries. How these long-term care facilities are run in the different Scandinavian countries also differs, which might have had some impact on it. So we will see in the end, but I think one of the lessons for Sweden is that we really need to improve the quality of our elderly care in these kind of homes in Sweden. So you can also look at the development of our pandemic in different ways. There's been a lot of discussion on testing and how much testing should be done and when it should be done and who should be tested and so on. Sweden unfortunately had a fairly low capacity for testing in the beginning, and then we increased it sharply. But as you can see here, when you look at the percentage of positive cases in the beginning, it was way too high. I mean, we were up to almost 20% of the people that were tested during the early phases. But then you have to remember, during those days, the capacity for testing only reached to test people that were going to be admitted into healthcare. So that you need to remember that right now, later on, when we are in the late summer, early fall in Sweden, we have a much higher level of capacity to test, and now we're basically testing everybody who has symptoms. And then we're down to a level of only a few percent positive of the now 130,000 tests that are run every week in Sweden. Many people look at different data to see how the pandemic evolves over time. Mortality I think is very difficult because mortality will so much depend on the structure of your population, how old they are, what kind of diseases they have in the background, as Dr. Fauci showed, will very much impact mortality, and it's not a very good indicator for how the pandemic evolves. If you just look at diagnosed cases, that will also depend incredibly much on your testing strategy, testing capacity. So we believe that how many cases that are admitted into ICUs is probably one of the better things to look at. It's at least in countries where you have a high level of capacity in the ICU. So of course, if your ICU capacity is overrun, it does not work anymore. But in countries in Sweden where ICU capacity has always been able to cope with the pandemic, we had always had like about 20% of the beds have been free. I think this gives a good indicator. And here you can see how it evolves over time. That at the peak of this, we had in Sweden almost 300 cases admitted per week into the ICUs of Sweden. ICU capacity in Sweden increased from less than 1,000 beds at the early start of the pandemic to almost 2,000 beds at the peak. Now we are closing down a number of the beds because they're not needed anymore. Because as you see in the late summer, early fall, we are down to only a few cases admitted into ICUs. And I think the last report was that there were around 17 people in ICUs anywhere in Sweden treated for COVID-19. So it's a dramatic difference to when we had almost 300 cases admitted every week. How it affects different age groups is, of course, also very important. And here you can see the incidence in different age groups. And you can also see that the total incidence has gone down dramatically during the summer. But the big peak you see in the beginning, incidence-wise, was the very old, the 80 plus people, because they were hit the worst very early on. And I think this is a graph that is, we do not really understand whether we had so many of the elderly people getting infected early on in the pandemic, but it's quite a big difference to many other countries, and it probably also reflects the high level of mortality that Sweden has had early on in the pandemic. You should also know that now during the last couple of months, the spread of the disease in the long-term care facilities in Sweden has gone down to almost zero. And our mortality is now down to single cases per day in all of Sweden. So all the efforts that's been made in the long-term care facility has really paid out. The fall into cases from these facilities, as you can see, fell much, much earlier than the fall in the rest of the population. Dr. Fauci also mentioned mortality in different groups, and I also said repeatedly that it's the mortality from this disease is very age-specific. Other diseases does also play a role, but at least in the Swedish population, age is the main, really very important risk factors. As you can see here, it's the very old that do have a much higher level of mortality than other groups. And if you go down to younger people, mortality is almost non-existent. There is also a striking difference between men and women. This can be seen in most countries, I think. Women tend to be admitted to healthcare more often, but men do get more severely ill and definitely die more often than women. Dr. Fauci mentioned something about immunity. I will talk a bit more about how can you try to measure immunity in a population. How important is that, and what does it mean for the spread? In Sweden, we have found that it's very difficult to estimate any kind of level of what you call herd immunity or immunity in the population, basically because the spread is very heterogeneous. We have regions in Sweden in the very south which had almost no spread, in spite of that the population density-wise and in many other respects look very much like the Stockholm region, who has been very severely hit. So there is an enormous heterogeneous between different parts of Sweden, but also even within Stockholm. We know that certain parts of Stockholm we have a very high level of immunity, while in other parts of Stockholm there has always been no disease at all so far. So this heterogeneous is probably to a certain extent connected to these super spreader events. I really like that description, because I also don't think that this is the individual that decides that's going to be spread a lot. It's much more the event, the environment that you happen to be in when you can spread a disease. That's very important. So we have a level of about 18.7% in highly affected areas. We are maybe around 7 to 10% nationwide. We recently, last week, did a randomized survey among 3,000 to 4,000 people and checked how many were PCR positive among people without symptoms, and we found none. In earlier surveys, we have found a couple of percent people being affected without having symptoms. But once again, asymptomatic people are very difficult to know how many they are, because when we have interviewed this small number, but still number, almost all of them have had slight symptoms. So I think here, I'm not so convinced about that we have this high level of completely asymptomatic people, but there is definitely a very big group of people who have very light symptoms that I would not notice if you didn't ask me about if they felt completely healthy or not. There has also been a lot of rumors about people that Sweden was trying to reach herd immunity as quickly as possible, and I would like to once again deny that. We are not trying to spread the disease as quickly as possible, rather the opposite. We are trying to slow it down as much as possible. So what happened in Sweden? We had a massive introduction in Sweden in February from many different countries, not only from the Alps, where it was spread very much, but also from the UK. We even have cases that came out of Boston in the US and so on very early on, because the week when this was spread very much internationally, not least in Europe, Stockholm and the surrounding regions had a holiday, and at least 1 million people were out traveling during that week, which I think is one of the reasons why the pandemic hit Sweden more than many other countries. It worked reasonably well in the beginning in the containment phase. We caught a lot of people coming back from skiing in the Alps. We did a lot of contact tracing and broke basically all of the transmission chains at that level. But eventually, too many people came in with a disease from different parts of the world. And we went into kind of mitigation phase. That lasted for a month or two. But from June and onwards, our testing capacity came up, the number of cases came down, and we are back into kind of containment period where we do a lot of contact tracing and a lot of testing. We have limited the spread with a number of binding regulations and voluntary measures, and I'll come back to describe them a bit better. So what did the government do during this pandemic? And what were the goals that we were trying to achieve? As I said, we were not trying to head for herd immunity, not at all. We're trying to slow down the spread as much as possible, which I think most countries were. We would like to see that healthcare resources were available, and they were all the time. I mean, the healthcare in Sweden transformed to a great extent, focused on doing COVID-19 treatment, and that meant that everybody really got the treatment and needed it. We would also like to limit the impact on critical services in society, and the society in Sweden kept on working the whole time. This government also have done a lot of things in the economy to limit the impact on companies and the economic level. We have worked very hard with communicating with the population, daily press conferences and other things like that. We worked very hard to continuously evaluate the situation and try to have the right measures in place at the right time. As I said, minimizing the transmission has been the overall goal, but the goal has also been to protect the risk groups. It was not very successful in the beginning, but now during the last few months, it has worked very well. We have very few cases among the elderly in Sweden now, and when we measure immunity, the elderly has at most about half the level of immunity that people in other ages have. We would also like to have a sustainability in our response strategies. Closing down completely and then opening up was something we already from the beginning thought was going to be very difficult, and it's also been proven that it is difficult in many European countries right now. We are now working more and more that the response needs to be flexible, because since this is so heterogeneously spread, you need to have responses adjusted to the spread in different regions, even in a small country like Sweden. We are quite concerned about other health threats will pop up because of the response. I mean, isolating the elderly people, of course, leads to a lot of problems in that group. Closing down a lot of workplaces and so on also leads to a number of other health problems that we need to minimize as much as possible. And we're trying to do this evidence-based, not easy when you're working with a disease that we've never seen before. So we did it with a combination of binding regulations and voluntary measures. The binding regulations were ban on visiting nursing homes, for example. We did not close the schools. We early on decided that we wanted to keep them open, but decided on distance education for secondary school and universities. We banned gatherings like most countries have done to some extent. We are now at 50 people at the maximum for public gatherings. We all knew that restaurants and cafes were places where we see quite a lot of the spread. That was a knowledge from the Alps during the holidays there. So we had a lot of rules for the restaurants to make them as safe as possible. And we had in the early phases quite a lot of travel restrictions in place. And as I said, we communicated a lot with the public over time during media, quite a lot. So what did we tell the public? We told them, which I think is one of the most important things, stay at home when you're sick. Even if there might be a number of people with asymptomatic disease, we are quite convinced that the people with symptoms are the ones that spread the most of the disease. And if you can get them to stay home, you will slow down the pandemic. And that's what we can clearly see in Sweden has happened. People above 70 years of age need to be more strict about staying home and avoid unnecessary contacts, cut down on travel. We told people to work from home if possible. And it's quite possible for many people in Sweden with the kind of work most of people do in Sweden these days. We would like to slow down the use of public transport to avoid crowding in that area. Try to avoid meeting too many people, and of course, hand hygiene, hand washing, and cough etiquette, and all of those things were also communicated. To make this possible, especially to make it possible to stay home when you feel ill, there was a number of new regulations put in place that normally the first day you stay at home in Sweden, you don't get paid. But this was changed by the government to make it possible to people to stay home otherwise, and also to alleviate the pressure on the health services. Medical certificates, if you need to stay home for more than 2 weeks, were taken away. All of this to make it easier for both the health service and for people to stay home when they're sick. And there was also a compensation scheme for people in risk groups, so they could stay home with compensation and avoid being infected. As I said, the healthcare services during the pandemic transformed in an admirable way. A lot of elective surgery and other elective procedures were postponed, of course. There was a big challenge to get supplies for protective gear. Unfortunately, supplies in Sweden were very scarce for a long time, but now it's working a lot better. And as I said, the number of ICU beds doubled during this time. And there was a number of other measures taken in healthcare to avoid spread in the healthcare. And our impression, even if we haven't studied it very carefully so far, is that the spread in healthcare has been very limited in Sweden. Healthcare professionals have been infected, but not very much. And our feeling is that they were probably more affected by each other than by patients. And how did the public respond to our messages and so on? We have had a lot of surveys out asking people how they adjusted, and 80% of the people say that they adjusted their daily lives a lot during this time, and they kept on adjusting it even today, 6 months after the start. The trust in the public health agency and in the political level have been very, very high, were high from the start, but increased and is still on a very high level. We know that the compliance with recommendations has been very high. For example, traveling decreased significantly with just the voluntary measures, and even decreased more in Sweden than in many other countries in our surroundings. Primary schools are very important for child health, and it's something we believe very strongly in Sweden that we need to prioritize, and that's why we kept schools open. And so far we can see, and we have also compared ourselves to our neighbors Finland, that there was no ill effects from that. The schools got the same recommendations as anywhere else. Avoid big gatherings, keep good hand hygiene in place, stay at home when you have some symptoms. And there was a strong support from the society to keep the schools open. And it worked out really well without no negative effects that we can see at this stage. Face masks. I think I have a slightly different opinion about face masks than Dr. Fauci. Of course, we all agree that medical face mask is essential in healthcare facilities and long-term care facilities. But in Sweden, with the current compliance with the recommendations we have in place in keeping social distancing and avoid crowding and so on, and with the falling number of cases we have not seen any real need to make a national recommendations to use face mask in any setting at this stage. We still consider that face masks can be useful, and of course, if we see an increase anywhere locally in Sweden during the fall, recommendations will again be looked at and maybe introduced in certain settings to break the transmission during those local outbreaks. So the key points: we have really run containment and mitigations measures very much in line with other countries. I think the differences between Sweden and other countries have really been overstated. We have done them with more voluntary measures adapted to the Swedish situation, but basically we're trying to do the same thing. We have worked a lot with voluntary measures because there is a high level of trust, and we know that the compliance with the recommendations from the agencies are followed to a very high degree. So this combination of regulations and voluntary measures gave a kind of lockdown also in Sweden. Not a legal lockdown as many other countries, but in practice, the same level of lockdown as we have in many of our neighboring countries. But we will not know for sure who did the right thing and who did less of the right things during this pandemic. It's far too early to evaluate that, and I think we all need to be humble with this disease that keeps on surprising us with having new ways of both spreading and causing disease that we have really not seen before. So thank you very much, and I'm open to any questions.
Dear Dr. Tegnell, thank you so very much for this interesting talk that demonstrates your vast knowledge. And this spring, for now, I think almost 7 months, you have been the function chief, the wise leader, guiding the society in Sweden in a very difficult time. So I would like to initiate one question. How have you managed to maintain your conviction during this intense and demanding period, when criticized sometimes heavily by scientists, politicians, and the public? What is the thing you can transmit to us, how to be convinced in what you do and provide that to the society and keep on doing it?
I think the main thing to do is to see to it that you have a good group of people around you that you can work together with, that you can discuss things with, and feel confident that you have really looked at every angle of a question, so that you feel really convinced that you have really thought about it in any possible way and you arrived at the one possible answer in the context that you exist in. And I think we should also remember that the trust from the public has been enormous. I mean, the Public Health Agency for a while received flowers in amounts that has never been seen before. I mean, Swedish agencies are very trusted and I think well thought of, but sending flowers to public health agencies is not a common thing to do. But there were floods of them basically during a period. So I think the other reason why we, not only me, but also my colleague, have kept on with this is that the enormous support from the public in what we are doing.
So you were heavily involved in the swine flu epidemic, 2009. How much did that influence or help you in the current situation with COVID-19? Did you think in parallel, or did it even mislead you as thinking it's the same type of pathogenic event and same type of viral replication path, pathogenesis? How did you think about that? Or is it just by conscious, you experienced this before and now I do the same thing, or did you think in completely way?
I think that's a very good question, because of course I've been thinking quite a lot about the similarities and differences that there has been. And I know a lot of people in the beginning said you're comparing this too much to a flu pandemic. I think there are differences, but there are also a lot of similarities. in how they behave. So we should not dismiss that you can learn a lot from flu pandemics also when you're dealing with this COVID-19. On the whole, I would say what I really took with me is how important it is to have a dialogue with the public. You need to communicate in a way so that the public understands what you're trying to achieve. You're not just telling them to do different things, but also really trying to tell them this is what we're trying to achieve together. We believe if you do this and that, we will reach there. You might, as public, want to do slight variations to that, but as long as we can agree on the goal, then I think that's very important. And try to understand what is the main questions that the public needs to have answered. I think that's very important, because I think through all pandemics and also very much through the different Ebola outbreaks in Africa, we can all understand how important it is to have the public with us when we're dealing with a pandemic. And I think the experience from all other countries, including the US, is showing the same thing. If you don't have the trust from the public, I mean, you can be ever as good scientist and have the best reasons in the world for different things to happening. But if the public don't trust you, don't understand why you're doing this, they will never comply.
So how should we, you think, interpret the current situation, so different from the United States, with about 30,000 cases, at least, new cases per week? And you indicated here very restricted numbers and a significant drop now in Sweden. And then you demonstrated antibody levels of somewhere 15, 18% and maybe 7% on the national level. What do you think about what has been very much discussed the last couple of weeks on cellular immunity? What is the role of the cellular immunity versus the humoral immunity? What is your opinion about these things?
It's not really my area of expertise, but of course I read up on it, me too. And I saw a recent publication from Iceland, which has incredibly good data from a fairly small population, where they show that 80-90% of the people actually develop antibodies. And I think there is a number of other publications pointing the same way. A lot of people do develop, maybe definitely majority, maybe as much as 80-90% do develop antibodies, but you need to measure them at the exactly right time, probably, because they don't come very early, and at least in some people they disappear fairly quickly. So I think that might be the reason why you in some instances have shown very low level of antibodies. But once again, it's a tricky disease, and T-cell immunity, I'm sure, plays a big role. But if you need to measure it to understand if a person is immune or not, that I think remains to be.
And it's
understood.
a very complicated thing to investigate, though, isn't it? I mean,
exactly. I mean, if you want to do something on,
but this is not easy on a national level to do.
No, if you want to do 3,000-4,000 cases, 3,000-4,000 samples within a week or within a few days. You cannot do T-cell immunity, then you need to do antibody testing.
Right. So I'd like to ask you the same question I did with Dr. Fauci. If you were to redo the guidance of Sweden again, and that would be the week 9 in Sweden, would you then consider something that, I should have done this instead of this? Are there things that has opened up your mind now when you have 7 months of experience in this, and now can say, maybe we should have done this and this instead, or?
I think there's a few things that we should have done, and maybe a few things we should have done even earlier than then. I mean, one thing is the supply of materials to our healthcare system. I mean, the level of stores were definitely inadequate, and that I think was a really unnecessary problem in a rich country like Sweden. We should be able to store and have things in store for our healthcare to keep working more than 1 day at a time. I mean, this caused a lot of stress, unnecessary stress to have it. And of course, we learned a lot on how to prevent the spread into our all care, long-term care institutions. And those lessons we need to take with us, because it's not only COVID-19, it's the yearly flu and it's antimicrobial resistance, so many things spread in those facilities, and we really need to be much better at taking care of that.
But on another aspect, as a society, how could we discover this outbreak in a more rapid way? I mean, is there a way to use regional, national, international data more interactive than what we have done so far? I mean, you consider all the data resources that are generated in the society. Can we sort of make them more interoperable so that you get hints, ideas in a much more rapid way? And I think of the start now, like you said, the Swedes were traveling and you got in Sweden a very bad start on this, and you've done. So are there means which we could develop now for the next pandemic, where we actually can see things like weather stations, or I don't really know if if you consider all the data generated in society, contacts, digital contacts to health, cell phone interactive things, other ways.
Yes, I think we come a long way if you compare to the SARS outbreak. I mean, we are enormous way beyond that in collecting and coordinating data through WHO and through other agencies. It's become much, much better. But again, I do believe we could become much better at analyzing the data we are collecting from different countries. We still have a very scant knowledge on where does actually most of the transmission takes place. Most likely in the home or at the workplace. But what other places do we really need to work with to stop this? And we could have had, I think, better data on the pathogenesis of the disease earlier on if we collected data better than we did. We contact traced enormous amount of people on flights during the first few weeks. Using that data better, we could probably have a much better idea on exactly how dangerous it is to fly with COVID-19. Most likely it's not very dangerous, but since nobody really collected that data, we don't really know. So I think there's a number of things we could do better together, for sure.
So my last question is to you. You pointed out that the Swedes have a very motivated public trust, to what you have pointed out and demonstrated. What do you think we can teach other nations how we do this? Is this unusual for Sweden? Or is this something that is common in European communities? Or is there something peculiar? You pointed out that we have had for 300 years, the departments and institutions, and that we have built our society for individual departments that have done. But where does this come from? And are there things we can learn how to generate public trust? Because I think that is in nowadays we are sort of, I wouldn't say polluted, but it's raining, information. And part of it is very good, part is not. So how do you generate public trust in science and health professionals? And what can we as scientists and health professionals do to maintain the trust in the society? Because I think you pointed out, and it's probably a key thing to what has been achieved now.
Oh, and I think Dr. Fauci also were into the same thing. It's very important. And I mean, this is a question of building. It's not something you create once you have the pandemic going. So it's something you build over time. You need to be very transparent, very open. But I also think being able to listen to your public and understand their concerns, and maybe not being too much of an academic, instead trying to understand that these are the questions that the public have. They might sound stupid to you, but they need good answers, and they should get good answers.
Right.
And if they do get that and feel that you're really listening, understanding their concern, I think then that's a good start of building a level of trust.
Right. So my very, very last question is, in line with Dr. Fauci, will we have a vaccine or several vaccines by the first quarter of 2021? Or what is your perspectives on vaccines in the pandemic? And
No, I think with the massive amount of resources that have gone into vaccine development right now, and with so many different vaccines, because it's quite good that the vaccines are so different, building on different vectors, building on different technologies, that the likelihood that at least one of them would work reasonably well is very, very high.
Good.
On the other hand, I think the big challenge that you also talked with Dr. Fauci about, how do we get the huge amounts of vaccines that are going to be needed produced quickly enough for them to be useful. Because it's one thing to say that we might have a vaccine available in the end of the year or early next year, but available is not enough. I mean, available, we're going to need billions of doses and distributed all over the world in a good way. And that's going to be a big challenge for
the whole infrastructure also, not only the production, but the infrastructure.
The infrastructure, the people that can give the injections, the people that can follow up so that we see any kind of events happening that we need to take care of and so on.
Once again, thank you so very much for accepting to give the Murdock lecture together with Dr. Fauci. And it was fantastically interesting to listen to you and your wisdom. Thank you so much, Dr. Tegnell.
Thank you so much for letting me be in this wonderful event.
Thank you. Now I will leave the floor to Dr. Stegnell.
Again, Dr. Tegnell, I also want to thank you profusely for accepting the invitation and giving the lecture. Again, you also won't receive any cash, award for going with this lecture, but we'll also send this humble, plaque to hang on your wall, and hope to come across sometime later. Thank you so much, Dr. Tegnell. Again, I want to thank all the participants, all the audience, and hopefully next year we can have this meeting face to face. And looking forward to 2021 meeting where it has to be a face-to-face meeting. And Jan, you have something else to say?
May I just a few words to say thank you for all participants. And it's time, like Dr. Nair said, to close this 26th Annual Mayo Clinic Karolinska Research Meeting. It was the first time ever that we had the virtual meeting of this annual conference, which is a part of our strategic collaborative platform between Mayo Clinic and the Karolinska Institute. So we've had 2 days covered a broad range of topics, including autoimmune disorders, cancer, cardiology, cardiovascular biology, diabetes and metabolism, psychiatry and psychology, regenerative medicine, individualized medicine, and education, nursing science, and healthcare management, as well as innovation. Pretty much covered medicine. And all of this has been done in a virtual online interactive platform. We've had very intense plenary sessions, and the breakout sessions have been packed with more attendees than ever. In networking session, people have been discussing ongoing and new research projects. And the poster presentation has been in a very novel way, making it possible for us to comment and connect with scientists. So we are very interested in getting your views and comments on how you have experienced this meeting, since it's completely new for us. The evaluation to all of you will be sent out on Monday. Please give us thoughts back. So thank you, all Transform, the collaboration team, the chairman, speakers, the organizing committee, as well as the participants, for making this into what we believe a success that has broadened and strengthened the scientific and cultural bridge between our two organizations. So just to finalize from Dr. Nair and myself, you are most welcome to the next year Mayo Clinic Karolinska Institute Annual Research Meeting. And it will be announced at our two websites well in advance. So on behalf of the Mayo Clinic and Karolinska Institute, you are most welcome, and we look forward to seeing you next year. Bye-bye, everyone.
Thank you, Jan.